My first slide is sort of a disclaimer slide, which is the purpose of this brief session is to stimulate discussion. So I'm trying to be provocative. And I also need to make the disclaimer that I am not now nor have ever been an ethicist. I do cluster randomized trials for a living and have done so for a while. So that's my interest in the area. So I will talk about the topics that were introduced so well by Charles, namely equipoise, risk-benefit assessment, and then hopefully raise a bunch of questions and have a vibrant discussion. So first, I would like to say that I'm going to get ahead of myself and say that I completely agree with Charles' conclusion that equipoise is applicable to cluster randomized trials. I do, however, disagree with framing it and justifying it in the way that he does. And so I just reworded the definition of equipoise because it suits my purpose. And I'm saying it in the affirmative rather than the negative. A trial is unethical if one arm is known to produce better outcomes than another, but I think we'd all agree on that. And the argument that I do not completely agree with that Charles made is that in order to invoke equipoise, we need to invoke the fiduciary relationship between the physician-researcher and the state and the research subject. I apologize for the subject, but at least it's between quotes. So, and I would like to, the argument that he's made, and very well, is that there are two reasons to invoke equipoise and in the RCT contest: the fiduciary relationship and the asymmetry of power, which is mitigated by trust. And in the case of the RCT, it's patients and physicians that's being quoted, and in the case of CRTs, it's citizens and state. But I do have a bunch of questions that came to my mind when I tried to understand these concepts. Of course, the first one I've already stated. Do we really need to anticipate, to invoke physician-patient relationships to discuss equipoise in RCTs? I'll come back to that. This may sound strange from somebody coming from south of the border at this time, but I am not one of those American citizens who thinks the state is the enemy. And therefore, I really think that the state should ensure that all research involving humans, individuals as well as groups of humans, should be ethical. I don't think that we need to invoke trust. I think that's just a fundamental principle of democracy. And then the third question is, given those two questions, which I've already told you how I would answer them, I don't see a reason to say that equipoise would not apply to cluster randomized trials. What the previous questions were really based by my instinctive, if you will, reaction to asking, is the physician-patient relationship the right model to discuss a randomized controlled trial? RCT now, let alone CRT. Not all investigators who conduct RCTs are physicians or even clinicians, and not all research subjects are patients, yet we do lots of RCTs, so we don't need to invoke that. The informed consent aspect is a guiding principle for all human experimentation in my mind, and I think in the sense of the regulatory agencies. And the asymmetry of power, in my mind, is actually higher in the clinical encounter than in an RCT. But again, this is an opinion. However, as many of things in ethics, we invoke principles and we make decisions based on opinions. So what I would like to propose is that RCTs and CRTs are actually ethically closer to one another than either is to the clinical encounter. And the table below focuses on uncertainty, which is, in the case of the clinical encounter, controlled or mitigated by the physician's best judgment, but in the case of trials, it is imposed. The uncertainty is imposed. Chance is a force in the trials, whatever they are. Informed consent is only implicit in the physician-patient encounter. It is explicit when we decide we need it in both of the trial situation. And equipoise is only involved implicitly in the clinical encounter, yet explicitly in the trial situation. So for these reasons, I would make the assertion at the top of the slide. So I would propose an alternative framework that states that equipoise is imperative for all experimentation affecting human subjects, individuals or groups. Equipoise should be present at both the individual and group's level. And indeed, that is what Charles applied to the BedNet study and many other examples. So now I'm going to transition to the second part of the conversation, which is the harm-benefit analysis. Equipoise, as we know, focuses on lack of known superiority for the main question posed by a study. But this superiority is not along a single scale. It's not unidimensional. We need to understand, and hopefully, although frequently we cannot, quantify the possible harms and possible benefits for everything we do. And traditionally in the RCT, we do that for each individual in the study, i.e., we use the individual perspective. I ask, should we also use the perspective of the group, of each of the groups that is randomized, or should we also use the perspective of society at large? So these are questions I just throw out there for discussion. I do think that the component analysis that was proposed is a very useful framework in attempting to distinguish between therapeutic and non-therapeutic. And as Charles said, sometimes it's not so clear what is what. And also, the other thing that we need to keep in mind is that most studies, although they test an underlying question or several, but they involve many different procedures. So I was trying to understand the reach of this component analysis approach, and I try to understand things by making tables, as you might have noticed. So I tried to understand what exactly was being proposed, and it was very clear to me that in terms of the intervention group of, say, a two-arm trial, the therapeutic procedures should be evaluated by whether their potential benefit outweighs their harm. It was also clear to me that in the control group, the non-therapeutic procedures should be evaluated as to whether the harm has been minimized. But individual benefit was not on the table. What was not so clear to me was how we were going to handle non-therapeutic procedures for the intervention group, or more importantly, the therapeutic procedures of the control group, for which there are some. So those are additional questions to think about. And so I would like to add a few more questions about this concept of component analysis and how it's applied. Minimizing harm is a very tricky term, in my opinion. It's in the eye of the beholder. And whether we use component analysis or not, I bet different ethics boards will come up with different answers to what minimizes harm. Implicit in what Charles did, actually quite explicitly, when we were talking about non-therapeutic procedures minimizing harm, there was also the issue of and resulted in a better social good. So it shifted the perspective from the individual to the social good, which in my mind is correct, that should be done. But it's not clearly articulated yet. I would propose to make that clearer. And then another question I would like to ask is, can the risk of a non-therapeutic procedure be balanced at the individual level by the future benefit to that individual who's undergoing the procedure? I really don't know. And finally, is the cost of a procedure part of the harm-benefit discussion? This issue was raised this morning. I think Kathy raised it, and several other people came back to it. And I think it's something we have to deal with. So this is my final content slide. And so I would just like to add a few more questions to the pot. I do a lot of implementation trials, so that is near and dear to my heart. So one of the questions I would like to raise, and I would like people to pay attention to, is in the individual randomized controlled trials, there's a lot of, it's en vogue right now, and justifiably so, to talk about non-inferiority trials. I think we need to do that as well in cluster randomized trials, but I haven't seen it happen. Maybe somebody here has done one, but I haven't seen it. The other question is the statistical inefficiency that was alluded to this morning, which is clearly there and is well justified. Is it an ethical issue? Do we need to talk about the cost of that statistical inefficiency? And finally, there was a question raised this morning. I made these slides yesterday. So I do think that data safety and monitoring boards have an important role to play in cluster randomized trials. I've been a member of a couple of these. And I do think we need to pay a lot of attention to stopping rules, which, as was said this morning, have not been developed yet for the cluster randomized trials. And that's the end of my slides.